So today we are going to be talking about Plaster of Paris, POP. Okay, so if you haven't subscribed, please subscribe and hit the bell notification. Okay, so the Plaster of Paris is made up of hydrated calcium sulfate, or also known as gypsum. Then the Plaster of Paris or gypsum salt is actually made up of calcium sulfate. That's the chemical formula, calcium sulfate, then have H2O, and that's in dry form. And when you put it in water, it actually becomes calcium sulfate 2H2O after it's soaked. Then this conversion is an irreversible exothermic reaction. That's what happens after you put it in water. That's why patients start saying that it's getting hot. So then the plaster sets in a given shape on drying, and setting time varies with its quality and temperature of water. So if you put it in hot water, it usually dries off fast as compared to cold water. That's how it is. Then you can use it in fiberglass. Then there are also other uses of plaster of Paris in. You can use it in two forms, that is the slab or a cast. So in our setup we call it the back slab and the full cast. Then slab and casts. So these are just methods of a temporary mobilization for a wide variety of musculoskeletal conditions, not only for disorders of bones but also for many disorders related with tendons, muscles, and soft tissues. So a cast or a full cast, these are circumferential immobilizers which is surrounding the whole circumference of the limb. But a slab is these are just non-circumferential immobilizers which only support a part of the circumference of the limb. Then a cast. So a cast has its advantages. So we have a cast is more effective mobilization with less probability of displacement than slab, because it can also be used in some cases of postoperative internal fixation for initial support of the affected fixed limb. That's some of the advantages of a cast. Then that's one. Then indications for a cast: we have primary management of a simple and stable fractures, for example in place scaffold fracture, and in place well reduced college fracture, reduced fractures of both bone form in pediatrics. For the mid shaft, for example, a mid shaft radioulnar fracture, can use it for after it is reduced, you can put it. Then for isolated non-displaced unimadular post fracture, that's another indications, and a lot of other things which may not have been included here, of course. But these are just orthopedic indications. Then disadvantages: the casts provide better immobilization but are less forgiving, as it does not allow swelling, and it can act as a compressive force and irritating material for the skin, so it has a higher complication rates. So some of the complications are ischemia, heat injury, pressure sores, skin breakdown, infection, dermatitis, neurological injury, stiffness, and compartment syndrome, of course. Then application of the cast. So we are, like we said, you can use it as a plaster. Types of the active substance of the cast. So sometimes the casts may be made up of plaster, or it can be fiberglass. So the general principles for application of a plaster is that it's important to maintain good anatomical fracture alignment, then acceptable angulation, which varies depending on the fracture site, and you should active fix joints above and joint below the injury. So if someone has a mid shaft radioulnar fracture, so you make sure you have to, since the above is the elbow joint, then below is the wrist joint, so you have to immobilize those two. So that's what it means. You have to fix those joint above and joint below the injury. That's what it means. Then stable fractures are generally re-evaluated within 1 week following cast application to assess cast fit and condition, and to perform recent radiographic studies to monitor fracture alignment. Then displaced fractures require closed reduction followed by a partial casting and a post-reduction radiography to confirm bone alignment, then complete the cast for the proper condition. So that means if the bone is displaced, you first start with a partial casting, which is a back slab. So you start with closed reduction followed by a partial casting. You do a partial casting, which is a back slab. Then after 2 weeks or a week, you confirm bone alignment. Then you remove the back slab and you put the full cast for proper condition. That's what this point means. Then if reduction or positioning displaced during the follow-up, agent reduction should be performed. Then you have to reapply the cast and prepare the patient for operative internal fixation. That's if what has happened. Okay. Then steps of applying the cast to the limb, so the full cast. So one, you have to apply a circumferential application of the cotton padding to the limb where you are putting the full casts. So that's the first step. You apply your cotton padding. Then second step, you do a circumferential application of the plaster. So meaning you have already soaked it in water at this point, and you are now just begin to wrap it around the cotton padding of the affected limb. Then after that, you have to molding of the casts layer by layer. So that's what we are supposed to do. Then you also have to maintain the limb in the position of function. So the most mistakes people do is if the forearms, the upper limbs are easier to put, but the lower limb, we find that instead of putting the leg in its position of function, they put it straight. That's not the normal function of the lower limb. It's not supposed to be a straight where someone is as if they have straightened their knee joint. They are supposed to be in a position of function, so they have to at least flex a bit on the knee joint. And then, so this is what I meant by flex a little bit. Here, as you can see here, that's the position of function. So we have to place the injured extremity in its position of function. So if you are mobilizing like this, you have to, this is the position of function. This is also for the lower limb, this is the position of function. Then this trace, it's easy. Then finally, you should assess the pulse and capillary refilling for the casted limb to ensure that there is any compressive force over the vessels. You have to check if the neurovascular is intact. Then we have to prescribe the medical treatment for the patient in the form of analgesics and anti-edemators. Then you also have to tell the patient about the important cautions to be monitored, constantly make range of movements with the exposed fingers of the casts to avoid the stiffness of the fingers. Then you have to keep eyes on the edema and the color of the exposed fingers as well, and go to the emergency room quickly if there is bluish discoloration or severe edema. So that's what you tell the patient. And the essential limb elevation, of course, if the proper physiotherapy for the affected limb after removing the cast. So after you remove the cast, you have to make sure you send the patient to physio for rehabilitation. Okay. Then it's better to make a follow-up sheet for the injured patient for better monitoring of the injury and to register every incident. Cautions and the treatment, that this is not only better for the patient but also for the doctors as a medical legality, so for monitoring. Okay, then we go now to the slab, which is a back slab. So this is how it looks. So indications for a SLAB. So management of a variety of acute musculoskeletal conditions in which swelling is occurred or anticipated. So such as edematous fracture sites, sprains, or for initial stabilization of reduced, displaced, or unstable fractures up until orthopedic intervention. So for example, ankle sprain, swelling, fractured limb, preoperative management, postoperative support, and also for open fractures. So preoperative management is very important for slabs, because if someone comes with a joint fracture, then you are waiting for operative management. So make sure at least maybe you just put a preoperative management, so that at least you immobilize the limb. Okay, then that's for the limb. Then advantages: it's more safe than the cast, as it allows for the swelling with no compressive force, and it gives the chance for following up the wound in compound fractures, and the incision in post-operative internal fixation. The disadvantage is that it is less effective mobilization with more possibility of displacement. Then steps of applying the slab to the limbs. So same, you first apply your cotton padding to the limb you are going to put. Then you take the length of the area, you will apply the slab as it fixes joint below and joint above. Remember, joint below and joint above. So you get the plaster, then you measure, you take the length of the area you are going to put, and you have to make a 6 double layer plaster slab for the upper limbs and a 8 double layer for the lower limbs. So 6 double layer for the upper limbs, 8 double layer for the lower limbs. Then of course you have to select water. Then one side the application of the plaster or fiberglass, that's how it's going to look. Okay, then after that you have to apply now the crepe bandage on the limb now. So that's what we are going to do. Then after that you are going to prescribe the treatment for the patient in the form of analgesia and anti-edematous, and the range of movement for the fingers of the affected limb, like we talked about. Then of course you have to initiate proper physiotherapy for the affected limb after removing the slab. Then finally, immobilization with cast or slab is a race between the cure and the complications. So try as much as you can to help the cure to win the race before the complication sets in. And this will be achieved by a good management, monitoring the case, and remove the cast or slab as soon as possible. Then take home message: cast and slab are primary initial management with a high risk failure. Then you have to fix joint above and below, like we talked about. Then you have to assess pulse and capillary refilling after cast. So you have to make sure your neurovascular is intact. Then antidematous drugs are very important here. Then monitoring and follow-up are also mandatory. Then cast and slab are easy procedures, but you should respect their complications. So they are easy to put and everything, but their complications should be respected. And you have to remove as soon as possible, of course, with the rechecks of the x-rays for alignment and the like. Then you also have to start physiotherapy as soon as possible. Then we are done, and thank you for watching. If you haven't subscribed, you can subscribe, and see you on the next video.